All right, this is a quick review for pneumothoraxes and hemothoraxes. So we're assuming that you kind of understand the anatomy of the respiratory system. I'm EMSeducation.ca, and this is just a quick overview to help you remember what pneumothoraxes and hemothoraxes are. So the first thing is pneumothorax means air in the chest. Hemo means blood, so that means blood in the chest. The big thing we got to remember is that air goes in and air goes out, and the chest cavity is one sealed unit. And that's because of Boyle's law, where things move from a greater pressure to a lower pressure until it equalizes. That's how the chest works. So it needs to be able to expand and contract. So we're going to jump into it. So the first thing we're going to talk about is closed chest pneumothoraxis. So basically, that's where we have an injury to the lung, where the lung is actually being able to leak air into the chest cavity. So let's talk about primary. Um, it, they call it a primary pneumothorax, which means it's a simple and also called spontaneous. But primary basically just indicates that there has been a defect in the lung, usually called a bleb, where it gets kind of an ulcer. It will rupture and it allows air to leak into the chest cavity. And basically, what happens is then air will rush in through that hole into the chest and basically fill up the chest cavity. But sometimes, once that pressure equals out, you'll get pressure against the lung. And over time, a simple pneumothorax or spontaneous pneumothorax, in the primary sense of that it happening to the lung, will actually heal pretty easily once that pressure seals off. So they don't need a chest tube. They don't need um, any invasive really procedures for the most part. They just need to be observed and watched to make sure that their oxygen saturations stay high. So as an EMS provider, basically we just want to treat the symptoms we find and support their oxygen level. There's a what we call the secondary pneumothorax, which is still the simpler, spontaneous type of pneumothorax. And in this sense, this is usually caused from chronic COPD. They have some type of other medical condition that's affecting their lungs, stiffening of the lungs, and where they actually get a rupture of the lung and the air will leak out into the chest. And again, these people probably are going to need a more longer stay in the hospital. As EMS providers, again, we show up, especially at the BLS level or the EMR level, that we're just going to actually help them support their breathing through supplemental oxygen and get them to the hospital. And it might be a good idea just to let the hospital know that you're coming. So we talked about the primary pneumothorax. We've talked about the secondary pneumothorax. So now the next one we're going to talk about traumatic pneumothorax, and usually this happens from blunt trauma. We're talking about where the chest wall has stayed closed, so you get blunt trauma, whether you've been hit in the chest with a baseball bat, maybe you've had CPR done on you. Basically, that we've broken some type of rib and something has actually lacerated probably one of your lung tissues and allowed air to leak into the cavity. So again, this traumatic pneumothorax is just like the primary and secondary. Air will rush into that area, and then it builds up inside that area and actually could cause collapse to the lung. We're seeing with the traumatic pneumothorax versus like the primary pneumothorax, where you have it's a kind of a spontaneous thing. In the traumatic pneumothorax, if we get too much air pressure, as you can see here, we got the two blue arrows, and it's actually as the air fills up into that chest cavity, it's going to push against, collapse that lung totally. It's going to start shifting all that pressure over towards the heart, start impeding how well the heart can beat, how well it can contract. It will actually maybe even cause a shift to the trachea as well. So again, to maintain this as a BLS provider or an EMR, you just want to supplement with oxygen, keep those oxygen levels up. As ACPs, we actually might actually decompress this chest to let the air out so the lung can fill up again and we can ventilate and they can breathe better. But as the BLS and EMR, basically just supplement them with oxygen and phone ahead to the hospital and let them know you're coming. All right, so we've been talking about the closed chest, right? Pneumothorax. So the chest is still intact. The air pressure can't get in. The only way it can come in is basically through when you breathe in through your trach, and sometimes, like we talked about the pneumo, the air escapes through the lung. But in this example here, we're going to talk about the open pneumothorax, and basically that comes from some type of trauma, to basically usually some type of penetrating trauma. So we're looking at being stabbed, some type of puncture. Maybe you working at a construction site, you might get like a nail gun through your chest. You might also be shot. Those are the kind of things that go on. So when they do go through, you punctures the chest wall that allows that outside air to be able to go through the chest wall. Also, sometimes that if it's deep enough, you'll actually puncture the lung. So not only the air is coming through the chest wall, the air is actually coming through the lung at the same time. So with this happening is that we're going to cause the lung to collapse. So not always is the lung injured, but we got to remember that we need to close off this chest wall to maintain the integrity to allow that, because the air will follow the easiest path into the lung or into the chest cavity when you do that breathe in and breathe out due to that high pressure and low pressure change. So it's definitely going to go through the chest wall because it'll be easier to get in. So the current standard to treat this sucking chest wound or this open pneumothorax is what we're going to do is we're going to take a occlusive dressing, something that doesn't allow air to go in and out through it, and we're going to tape it to over top of that hole. Some people will use a tegaderm, which you can just put over top. If we're just using occlusive dressing, we're going to tape it on all four sides to make sure it stays sealed. Traditionally, we'd only tape three sides and leave one area open so air could still leak out. So we didn't develop a tension pneumo. But in times, what they're finding that is to really get that good seal to keep air from rushing into the chest from that hole, we've been taping all four sides. But again, remember, you got to keep checking in case you end up with a tension pneumo now because you've sealed off that hole. If it causes that air to rush in, maybe still through the lung where it's injured, and as it build up a bunch of tension, what you need to do is that just take off that bandage, let some air kind of come out of it, and then put the bandage back on and make sure you seal it up. Again, maybe call ahead to the hospital and let them know you're coming. They would probably appreciate that. So now the next thing we're going to look at is the hemothorax. And basically, we've had some type of injury, whether it's blunt trauma, maybe we've lacerated the inside of the lung kind of thing, and we actually have some vessels that are actually bleeding inside the chest wall. So what we're doing is we're getting a accumulation of blood between the chest wall and the lung, which is eventually going to cause that lung to collapse because it is thick and it doesn't have the ability to actually expand when they breathe in. So the biggest thing about this treatment is that this just makes sure that we can position the patient, as long as they don't have C-spine precautions, we can elevate their head, kind of make it dependent so the blood goes to more of the bottom area of the chest so that maybe they can get more air into that lung if it's still there, recruit some more space. We can also tilt them a bit towards the injured side so that way the pressure isn't leaning on the good side where we have that really good lung that we need to keep ventilate. But also the biggest thing is let's take a look at the oxygenation and make sure that we're oxygenating this patient really well and transport to the hospital as soon as possible. Once we realize that we're in this situation, this is a critical patient, we need to get this patient loaded into the ambulance and get moving to the nearest hospital that can treat this patient. And then give them a heads up that you're on your way because they'll really appreciate that. Thanks for watching. I'm Jason Jolson, and this is emseducation.ca. You learn online, and if you want to learn more, just come to our website and take a look. Thanks for watching. I'm Jason Jolson, and this is emseducation.ca. You learn online.